So welcome to today's webinar. It's going to be presented by Dr. Nabil Abouchala, who is Welcome to today's webinar. It's going to be presented by Dr. Nabil Abouchala, who is a clinical associate professor of medicine at University of North Dakota. He's also an assistant professor of medicine at University of Alabama in Birmingham. Dr. Abouchala has extensive experience in critical care and pulmonary, and he works with us here at Sanford Health Institution as a consultant in critical care medicine. He will be talking today about current insights in ICU nutrition. We'll see the updates in terms of the guidelines and what's new in this field. I want to remind everyone that if you missed any of the previous webinars, they are available at www.icureach.com under the webinars tab. For future events, just hover over events and you can register for the next webinar, which will be given by Dr. Hassan Hawa about how to conduct the ward round efficiently and comprehensively. It's going to be on September 13th next month. It's going to be at the same time, 9 p.m. Riyadh time. If you have any question, please in the question and answer section, and we will get to those at the end of the webinar. Also, for those who are following us on YouTube, please put your comments or questions in the comment section, and we'll get to those questions at the end. Nabil, it's all yours. Thank you.
Thank you, Mazen. Really excited to discuss these issues about ICU nutrition. I been reviewing this topic for the past probably 15, 20 years, and as recently as I was trying to look at the updated literature, and you notice how controversial issues are, but I didn't realize it's going to be as controversial as it's going to be in the next few slides. So I hope I can make it clear at the end, but we've been really in true circles regarding many of the important targets that we use in nutrition. So with that being said, yes, I can't. My slides are frozen. One sec. Okay. Let's see. Stop the share for a second and go to. Okay. Okay. For some reason, I can't move my slides. Here we go. Okay. Apologize. So some of the issues that I think we all wonder about, and I think this is where changes have been recommended recently, is what target when I want to feed my patients in the ICU, what it should be my target, and in general we're talking about calories and protein. And then how soon should I feed my patients when many of us admit patients at night, and how should we start right away? Should we start within 48 hours? Should we start in the first week? And then, there was always the options of doing enteral versus parenteral. I'm sure most people would go on the enteral route, but what's the evidence behind that? And then again, you'll see quite a few papers being published in the past 10, 15 years about, should we feed the patients to full target? Should we do what's called trickle feed or trophic feeding? Or should we go to what's called hypocaloric feeding? So all of these things can put anyone into a state of confusion about what should I do. So these are the main things that I will discuss today. in the time that we have. And we certainly like your questions at the end. I won't be able to cover everything related to nutrition. Would require a full day symposium. So this is just to show you the progression. Compared to sepsis, we don't have too many published guidelines. And we have ASPEN and we have ESPEN. So ASPEN is the American parenteral and enteral nutrition guidelines, and ESPEN is the European. Most of the time, they're congruent with each other. There are some minor differences about particularly parenteral nutrition guidelines and when to start it. So most of the detailed guidelines were in 2016. I'm going to use that as sort of framework for our discussion. And the 2022 were more of an updated, not as detailed as the 2016, but it's providing some updated papers and publications. Some of the, I think, remarkable publications were done this year in the 2023, so that you won't see these in the guidelines, and a lot of things would probably going to change in the next year or so based on these new papers. So with that being said, in 2016, this is the publication. It was in the JPEN and also at the SCCM, the Society of Clinical Care Medicine journal, published simultaneously, and talking about how we should feed adult critically ill patients. Now, with this is going to be the outline of my discussion: enteral nutrition, early versus late, gastric versus small bowel. Should we do it when the patient is hemodynamically unstable? Dosing of enteral nutrition, should we go trophic versus full? And trophic also has hypocaloric. How much protein? And then when it comes to parenteral nutrition, we have those terms. Should we do full parenteral nutrition, combine enteral and parenteral, or do enteral nutrition and do supplemental parenteral? And so you'll see this terminology. When we monitor feeding, there's a definition, what's called GI intolerance for feeding, which is quite common. We'd use gastric residual volume. A common entity we see as we feed the patient enterally is called refeeding syndrome. And then should we do continuous versus intermittent feeding? And then we have several formulas that have been designed based on the disease of the patients. We'll touch base on this, some immune modulating formulas. Should we use probiotics? Should we use glutamine? And then the role of micronutrients. And I concentrated on the most important ones, which is thiamine, vitamin C, vitamin D, and B12. And again, I'm not going to be able to discuss all these issues, so I will be touch base about some of the papers related, particularly the newer publications. So with this, the early guideline in 2016 said feed and feed early. We tend to put that in our admission orders. So the recommendation, do it within the first. So anytime we say early enteral nutrition, meaning in the first 48 hours. So it's okay if you admit the patient midnight and you want to check with your dietitian and get their advice on assessing the patient nutritional status. But all the early papers, and all of these were sort of small papers, they were not randomized, they were meta-analysis. You see all the papers say, and based on these papers, 48 hours, 36 hours, 24 hours, and all these papers say, well, there seems to be a trend to reduce mortality and infection, so feed the patient early. Now, I think that's going to paper, it's called the France study. Interestingly, it's because they use French-speaking ICUs, but that's a very large number of patients that were looked at. And again, it's a prospective cohort study, it's not a randomized trial, and looked, does early nutrition support improve outcome patients? And I want to take a pause here and say there is no study was done, and I don't think it's going to be done, where there's a study that say providing nutritional support saves lives or improves outcome. Improve mortality by comparing patients that we starve versus patients that we feed. So many times, if you're going to use mortality as your outcome, it's probably going to be hard to prove any modulation, because first, we're not going to starve patients, because we know without food, people would die. But how long can patient tolerate starvation? And this is going to be very hard to do. So now we're looking at manipulating the enteral feeding or the giving parenteral nutrition and seeing whether any of this is going to make a difference in mortality. I think it's going to be a hard sell. But this is looking at would it improve the patient outcome by feeding them early versus late. And so this is a complicated sort of graph, but I'll walk you through it. We're looking from the left side about the number of patients. So this is a very large cohort of patients, as you can see. And then we're looking at the time, and a lot of the studies look at the first 7 days. So here we're looking at how much calories the patients were provided on this graph. So if you look at the first one, we see that 50% of the patients in the first day don't get feeding. That's pretty common based on this cohort, and that probably applies to most of our experience. And then those who get fed early, you notice here how we go within the first 48 hours to the target, which is in here about 22 calories per kilogram per day. So that's called the early group. The late group is the ones that we gradually increase over this first 7 days. So that's called the late. So this is how calories increase over time. They both reach closer to 20 calories per kilogram per day. And then they looked at what happened to these patients versus these patients, early versus late over time. Now, if you look at no early nutrition versus early enteral versus early parenteral, the number here is too small to look at. But the early nutrition versus early enteral, we noticed that the duration of mechanical ventilation, all of these were significant values. And again, this is comparison between the two groups. They did this ANOVA study to do multivariate analysis and sort of adjust for the variables between those two patients. So we see in most of the important outcomes, duration of mechanical ventilation shorter, ventilator-free days more, ICU length of stay shorter, 28-day mortality less, and the ICU mortality was lower. So in all factors, if you don't feed them early, so this is totally opposite to the 2016 early observational studies, where said if you feed them early, they do better. Appears that if you feed them early, they do worse. So we should not push for full caloric intake in the first 48 hours. It doesn't mean we shouldn't feed them, but we shouldn't push for that target. So early nutrition is not helpful. Now, and this is, they did like a dose relationship between the number of calories per kilogram over the first 48 hours. And we see as you increase, there seems to be also a dose effect. More calories, worse outcome. Same thing applies to protein. 0.3 to 0.9, and more than 0.9, we see also increased outcome. And again, this is an observation study. It's not randomized. And the idea that in general, you're more likely to be able to feed patients easier when they're not as sick as those. So this may be biased study, but they mentioned they try to adjust for these variables as much as possible, but nothing is going to be as good as a randomized trial. Now, in this early nutrition effect, the same Francis study, we look at subgroup analysis of various type of patients, and these are the yellow highlighted are the significant p-values. So we see overall, again, no early nutrition seems to be better for the outcome for the mortality. Males do better, people less than 65. And again, it seems this group of patient 18 to 25, and those who are less sick, so the SOFA score less than 8, seems to also do better with no early nutrition. So again, take that as a sort of observation and as a reminder that it seems based on this large database that early nutrition is not beneficial to full target, and I need to correct that. Now, What about patients that are in shock? Those patients that are hypotensive, requiring vasopressors for various causes of shock. Most of the ones that were studied were septic or cardiogenic shock. And the previous, recommendations in the past, is enteral nutrition safe during a period of hemodynamic? This is again the Aspen guidelines in 2016. The recommendation then was withhold feeding until your patient is fully resuscitated and stable. Now that's a vague term. Does that mean, if I put them on Levophed and the dose is 0.2 mics and the blood pressure is adequate, can I feed or should I not feed? Because we work on stabilizing the patients, but using vasopressors. So the further comment here, if your mean arterial pressure less than 50, if your lactate is rising, if your patient is on escalating doses of vasopressors, then don't feed them. And that's obvious because you're concerned about mesenteric ischemia. And you look for signs of intolerance, meaning if your patient's getting more distended, the nurses are excellent about observing these things and saying, oh, I think the patient's not tolerating feeding. So if you see any of these signs in patients getting worse metabolic acidosis, and don't advance the feeding. But is this, so this is one of the very large databases. It's like 25,000 patients in Japan. Again, it's a propensity matched analysis. They looked at, does early enteral nutrition is beneficial on mortality on ventilated patients with shock. So again, these were patients that were all on vasopressors. And they defined the dosage of vasopressors as low, medium, and high dose in this definition. So less than 0.1, 0.1 to 0.3, and more than 0.3. And I think that is sort of the general consensus. Anybody receiving more than 0.3 mics per kg is considered high dose Levophed. So in those patients, they looked at outcome of these patients. So they had enough patients, probably the lowest in the high dose noradrenaline, and they wanted to see whether there was a difference in mortality by adjusting for the other variable in this propensity match analysis. So if you look at this 28-day mortality, again, the higher the dose of Levophed, you're going to expect higher mortality. That has to do with the nature of their illness. But comparing the two, in the low dose, early nutrition seems to have a bit lower, but none of these were statistically significant. If you look at the medium dose, again, seems to be a little bit less, but not statistically significant. In the high group, that difference becomes 1.4% or versus the others. So their conclusion is that it's probably okay to feed when you do low and medium dose noradrenaline, but not when it is high dose. And because it seems to lose its beneficial effect. Now, I think that this study probably is the best to answer the question, should we or should we not? And here I'm putting this over summary slide that Dr. Kerala put on the website. So this is on the ICU Reach website, which is the Nutri-REA 3 study. So there's a Nutri-REA 2 and 1, and most of these papers are published all in the Lancet and mainly French ICUs. So I wanted to spend a few slides on this paper. This is published in March 2023, because I feel like it has a lot of points we can learn from what happened to these patients. So the study is called Low versus Standard Calorie and Protein. So in this, many of the other studies sort of adjusted. When you lower the calories, you adjust the protein and keep the protein at high level. But this study did both. They lowered calorie and protein in one group and randomized the other group to normal target. So all the patient had to be ventilated, all the patient had to be in shock on vasopressors to be in this study. It was published actually last month, but that was the head of the print. So again, it included a little period during the COVID time, as you can see here, 2018 to 2020, all patients. So we have 3,000 patients, about 1,500 in each group, adults. they randomized them to get early nutrition less than 24 hours after intubation. And the randomization was either you do 6 kilocalories, so that's almost 25% or less of their needed requirements based on the formula they used, plus also quarter of the amount of protein, so 0.2 to 0.4, and comparing this to the standard target, which is 25 and 1 gram. And they looked at various outcome measures. And a lot of these also look at GI events as an adverse reaction of advancing enteral feeding in these patients with shock. So if you look at this group, I do want to point out, because most of the large randomized trials were from Europe, and particularly in France, their BMI is much lower than we see here. So most of these patients are not overweight, they're not obese. You can see the range of the BMI, and that may make you think a little different. Pre-existing malnutrition, 90% of them were well-nourished. So these were not malnourished patients. And the causes of shock, majority of time was sepsis, but they had cardiac and they had other causes of shock. Now, so I want you to see the target. They did achieve their target nutrition. So when it comes to calories, we have a very good, nice separation between the target group, which is the standard, close to 25 calories, and that was achieved within 48 hours, compared to the low calorie, and I'm going to call this trophic feeding, when you are about 25% of the target. The protein in this study was both also 1.2 versus 0.4 to 0.2 to 0.4. So also quarter the amount, again, trophic feeding with low protein, low calories. Now, if you look at these patients, and I think all the trials have shown this, when you do lower calories, lower protein, you end up also with less fluid. So how much this is contributing to the outcome, we know too much fluid is bad. So if you look at their fluid balance in the first 7 days, the difference between 11 and 17 liters. And for some reason, they always get higher fluid in the group that get standard nutrition. It's not all feeding, but maybe sometimes the flushing and so forth. Now, if you look at some of the outcomes here, we're looking at GI side effect. We see less vomiting, less diarrhea with hypocaloric or trophic feeding. The blood parameters, pretty much glucose, insulin requirements, lactate, liver enzymes, and phosphate are all better than in the normal caloric target. So all patients have less likely to become hyperglycemic, require insulin, have higher lactate, and have abnormal liver function tests. And we use hypophosphatemia as a marker for refeeding syndrome, so they're less likely to have refeeding syndrome. Now, with these changes here, if you want to look at outcome and mortality, again, it seems that all the patients that received hypocaloric feedings did better on most parts. So time to discharge is less here with a significant p-value. Time on the ventilator less, so it's about a 1 day difference. And then the GI events, pretty much all of them were less likely to be seen in the patients that received lower calories and protein. So the conclusion from the Nutri-Rea study is that calorie and protein restriction is superior and to giving patients standard calories in case those patients are ventilated with shock parameters requiring vasopressors. There's some people that argue that early feeding is actually harmful. And so it's a matter of semantic whether we call the early feeding is harmful or we say restriction is superior. So it's a matter of semantic, similar to when we talk about low tidal volume ventilation. The arguments was also raised, is low tidal volume beneficial to the patients, or is normal tidal volume is harmful? And I think there's a belief that like high tidal volume, normal tidal volume is harmful to the patients. And so you're just protecting them, that maybe full feeding to the patient is harmful. And by restricting protein and calories in the early phase of shock, would be is protecting them from the harmful effect of feeding. What we know in this, and there's a lot of physiologic studies and a lot of nutritionists that know a lot more about this than me, would tell you that the body there's autophagy that occurs, and there's cell death, and these are material that our body try to get rid of it. And if we overfeed and if we try to feed the patient in that phase, we are preventing this process from happening, preventing the loss of this material that the body get rid of during the phase. So you're really not allowing these patients to rebuild their protein loss, no matter how much protein you provide, because the catabolic process is ongoing related to the underlying condition. So at that time, we need to let the body rest until the recovery phase happens. And everything we're talking about here is the first 7 days. We're not applying to when the patient recovers and still goes into rehab, then everything is different. So with this being said, now people looked at, how low do we get with calories? So that's why you see the terms trophic, you see the term hypocaloric, and I want to define that a little bit further. So if this is 100% of your target feeding, if you feed the patients anytime more than 80%, that's normal caloric. Because most studies have shown that even if you target full feeding, you're barely going to achieve 80%, most of the time 70% of your goal. And if you do that, you're technically providing full caloric feeding. Now, hypocaloric feeding or permissive underfeeding is somewhere between 50 to 70% of the target. And then there is this called trickle feeding. Trickle feeding is, in general, we call it trickle. It's about 20 cc. So it's like almost 1 large tablespoon per hour. So that's trickle feeding is a 10 to 20% of the caloric requirements. So that's going to be close to less, about 500 calories per day. This is on average about 1,000 calories per day. And this is a full is about 1,800 to 2,000 calories per day for a normal weight person. So here's, I want to show you a representative of hypocaloric and a representative of trickle feeding. So this is one of the papers by Dr. Arabi, one of our former colleagues in Saudi Arabia, published in the Journal of Medicine, multi-center study called the PERMIT that looked at hypocaloric versus standard. So you see the ranges. In that study, they adjusted for the protein. They said, if we're going to give half the calories, but we're going to give the same amount of protein. So they gave the patient protein supplement to make sure that the two groups have the same amount of protein to prevent protein loss. And you saw the Nutriria study did not adjust for that. So they both got lower. The low calorie also got low protein. And this study they had equal amount of protein. Now, this study showed no difference in outcome, mortality, adverse events, GI, and the GI side effects were all very similar between the two groups. Now, the trickle feeding actually goes way down to 25% of the caloric requirements. This is one of the landmark trials called the Eden trial. So that was done on ARDS patients. And the theory is that if we don't feed them, maybe it would prevent the cascade of ARDS from increasing, maybe some inflammatory markers. So they wanted to trickle feed, particularly those patients who are severely ill with ARDS and paralyzed and heavy sedation. Many times they don't tolerate the feed. So 25% seemed to be what they use in this trial. Again, that trial showed no difference in outcome. So these are several other papers. So this is trophic feeding, as I mentioned, 10 to 20%. This is the Rice trial, which is the Eden. Permissive underfeeding, we're talking 50 to 70%. These are various also other studies. The Arabi had done 2011, 2015. And if you look at those studies, the average BMI is 29. These were younger patients than what you see in many ICUs these days with the increased number of geriatric population. These are the various comparison of calories between the groups. Most of them maintained same protein intake, which is about gram per kilogram. So with those studies, we see none of these studies have shown that there's any difference in mortality, infections, length of stay, ventilator-free days. So it's okay to give patients less calories. These are other studies that used hypocaloric, and the other one was trophic feeding. Again, none of these showed any difference in outcome, mortality, length of stay, and ventilator-free days. So I wanted to mention a little bit about protein. We talk about it because one of the major factors that we deal with is catabolism associated with inflammation, with sepsis, and leading to muscle mass and patients' weakness that keeps the patients in the ICU, keeps the patients in the hospital for a long time and requiring rehab. So if we were to supplement patients with more protein because of this protein loss, would that be helpful? And again, there is a study that was called the EFFORT protein trial, the EFFORT trial, that randomized patients to higher protein than the normal protein target. In this study, I looked, and about 40% of these patients were on vasopressors. The majority were not. Good number of patients, about 600 in each group. And again, published in the Lancet. Lancet have to have most of the papers on nutrition in the ICU. Mortality was exactly the same, 34 and 32%. There was actually a little sort of a subgroup analysis in the study that showed that it may be harmful in two groups of patients. Those who had kidney injury, getting them more protein seems to do worse. So favoring the usual dose with a significant p-value. The other one with people that are sicker, the higher SOFA score did also worse, and they favor lower protein. So the conclusion from that it seems to give extra protein is harmful in acute kidney injury and higher organ failure scores. So the muscles don't like it. There's a muscle sort of saturation effect. If you think that you're giving patients more protein, more calories, that you're going to be allowing them to build, but if they're ill, they're not going to accept it. So it's when the body is sick, feeding them or overfeeding them doesn't help, but maybe there is a message here that is probably detrimental. In general, this is sort of the recommendations for protein supplementation. Renal failure, we tend to give more because we have more loss in CRRT, hemodialysis, and in non-dialyzed patients, we try to give them lower amount of target protein. Now, I wanted to show one slide because we see quite a few patients in the ICU with morbid obesity. And so those that are by definition are, having BMIs 30 to 40 or more than 40. The goal in these patients is to also, first, you're going to use ideal body weight for those patients. So this is some of the recommendations is to give them low calories. So compared to their body mass, this patient is getting closer to 1,000 or 1,500. Normally, they would be probably eating 4,000 or 5,000 calories before coming to the ICU. So, and you give them enough protein. So that's sort of the recommendation here. And if you have BMI more than 40, so that might help you to lose fat during this patient's admission. But what we notice is that they really don't lose weight because they lose more muscle mass and they gain water. So overall, the weight appears to be the same until they start getting into the rehabilitation phase. Now, parenteral nutrition, something that we depends very much on our clinical pharmacists to order it and adjust it. In general, our role is to decide if the patient should be on parenteral nutrition and when to use it. And the guidelines have been sort of a little variation between the European and the American guidelines. So there are several scores that assess malnutrition. I didn't have time to go over what's called the Nutrique score, but those patients who are severely malnourished, you can give them parenteral nutrition the first 7 days. There's something called exclusive PN if you have severe malnourishment in those patients, but you still give them hypocaloric feeding because you're worried about development of overfeeding syndrome. Now, supplemental PN is a patient who's not getting enough through their enteral feeding, so you do supplemental parenteral nutrition if you can't meet more than 60% of the requirement via enteral feeding. And that also really relates mainly to those patients that have severe malnourishment. Now, these are, as you can see, quite complicated. There's a lot of some variation. This is a Canadian clinical practice guideline. There's an Aspen SEC guidelines for enteral nutrition, and there's the ISPEN, which is European. And I'm not going to go over these in details, but when you look at the slides, you'll see this is a summary. I did make a simplified slide because, I mean, and truly, we're not rocket scientists. We want to make this simple. So this is on this graph. Here we're showing enteral feeding, and this is here we're showing parenteral feeding. And this is the first 7 days. So if you're a patient in general, we want to give our patient enteral nutrition to everyone. And we want to give this polymeric formula and special formulas. I'm going to touch base on these later. So you want to do early enteral nutrition. Again, as we discussed before, we start feeding, but we don't feed to target in the first 48 hours. Now, if you have patients who have these criteria, so the BMI is close to normal and their score is more than 5, that's called the Nutric score. I mean, they're sick. So ARDS, mechanical ventilation, post-op patients. The recommendation initially is to do trophic feeding. So 6 to 8 calories or less than 500 in the first 48 hours. And then you continue that for the first 7 days. If you have a patient who either unable to tolerate this or is high risk, meaning severely malnourished patients, then you start with early parenteral nutrition. And that you would do it in the first 7 days. When you do early parenteral nutrition, you do it as a hypocaloric. You don't give the patients their target nutrition. You give them closer to 15 to 20 calories per kilogram, or 80% of their basic requirements. The RAE is the basic metabolic rate needed for that patient, and there are formulas to calculate it. So we don't give full feeding, we watch for refeeding syndrome, and we can do this for those patients who are high risk, meaning severely malnourished. And so after the 7 days, then you can increase the calories to their full target. Now, if you have, this is some of the variation here. If you have a high-risk patient and you cannot achieve your enteral feeding goal to more than 60% of the needs, then you do supplemental PN, and you do it on the 3rd day. Europeans say the 3rd day, the Americans say 7 days. Supplemental PN if you can't meet your target because of GI intolerance. Now, if you can't meet, as I say, so this is European guidelines. The Aspen guidelines say all patients can achieve 60% enteral nutrition. You do supplemental PN plus that enteral feeding. A lot of the theories physiologically about maintaining enteral nutrition is the gut mucosa and keeping the villi alive, which prevent translocation of bacteria. One of the theories of patients getting recurrent sepsis in ICU and getting ill is to maintain the integrity of the gut mucosa by giving them enteral feeding. So monitoring tolerance. Now, there is sort of variation of the definition of what's called feeding intolerance. These are some of the definitions written by Aspen, which is a European, in 2022, having those 3 criteria. First, you can't achieve your goal. So your goal are less than 80%. And then you have at least one of these, meaning either vomiting, regurgitation, diarrhea, or abdominal distension. So it's, but some people did, reviews of practices in various ICUs, and GI intolerance or feeding nutrition intolerance is some people, if they feel like the gastric residue is high, this is enough. But most authorities recommend that we combine, that we can achieve our goal and we're having GI symptoms. And sometimes you want to sort of consider non-enteral nutrition factors such as medications. And I want to hone in on the opioids. We use high amount of opioids in these patients, and that may be a cause for GI intolerance and gastroparesis and constipation, GI infections, and bowel anatomy. So now when it comes to the refeeding syndrome, this is a common entity. Surveys have shown that it happens almost 30 to 40% of the time. The hallmark is the development of hypophosphatemia, but it's also associated with unmeasured variable like thiamine deficiencies and hypokalemia. So in those patients, there are ways to manage them. This is one of the studies that shows that either you do this sort of a gradual increase of their caloric intake over time in the first 7 days, or this study did increase to target nutrition on those patients, but they were making adjustment and electrolyte replacements very actively, almost 2 to 3 times per day. That if you do that, you can achieve the goal either way. So either you follow the electrolytes very, very frequently and make sure the phosphorus and the potassium are corrected, or you do this gradual increase until you reach your target after 7 days. Now, I won't have time to go over the continuous versus intermittent feeding. The studies in general showed no difference in outcome when you look for patients' mortality, which I think that's beyond any study that I expect. Physiologically, we don't eat continuously. And there is this called a muscle saturation effect. If you feed the muscle continuous protein, it reaches a point where it will not causes any anabolism, and no building of the muscle occurs once it's reached a certain point of saturation. So physiologically, it makes a lot more sense to do intermittent feeding. It's probably easier to do because you do the intermittent boluses or the short infusions. But currently, there's no study to show a difference. Most of the fasting time between these studies was too short, is about 4 to 6 hours. And we're learning now about called intermittent fasting and its benefits on our health. But most of these require almost more than 6 hours of fasting to achieve the beneficial effect. We do lose a circadian sort of hormonal release that we normally have when we do intermittent feeding with periods of fasting. But again, at the present time, most people practice continuous feeding because of easiness, and we have yet to see a randomized trial to show benefit. Now, selecting appropriate enteral formula, there are several things that have been looked at, and I want to mention there were some immune modulating formulas. These were studied at the same time with the Eden trial, and ARDS showed no benefit. Probiotics, there's no clear benefit. There's suggestion that it may be helpful to reduce Clostridium difficile toxin-associated diarrhea, but that's the only sort of benefit. There was a questionable benefit of reducing ventilator-associated pneumonia, but that's been not shown in later studies. So there's really no statement in the guidelines about probiotic. Glutamine people were pretty excited about its benefit for skin and benefit and burns, but again, actually the study showed no benefit. There is a role of giving micronutrients such as thiamine and vitamin C, vitamin D and B12. Now vitamin C replacement, the high dose of vitamin C that has been advocated for septic shock, all the studies showed no benefit, and the last study shows some negative or probably harmful benefit. So when it comes to disease specific, some of you have seen, special formulas for hepatic failure, diabetes, COPD, renal, burns, and ARDS and trauma. And none of these specialized formulas have shown any benefit. The formulas we see now, variation in the concentration of calories and variation in the concentration of protein and the amount of potassium based on the renal function. So now when it comes to to summarize this, what we're seeing here, and this is one of the summary article, how to avoid harm with feeding critically ill patients. So this is the early fall. You start the first day and then you target this. versus either maintaining permissive underfeeding for the first 7 days or gradual increase toward target in the first 7 days. Now, there's no comparison between the two. We've seen comparison between this and that most of the time. And what we learned by giving early full energy, there's increased mortality, there's more infections, more GI complications, or some of the studies showed no difference in any outcome. So given that it's probably harmful and it's not beneficial, I think we should do this. And there is really no comparison between the two. Gradual feeds is something also acceptable. The France study have shown a little bit more infections, but no statistically significant difference. So with this, I'd like to finish. This is one of the patients who gave me permission to share his picture, was one of our ICUs. And you can look at this patient here. He had a tracheostomy. He had a feeding tube in his nose, but he was able to write. So I walked in the ICU one day and he was sort of doing this, come to me, and he's giving me a paper. And he wrote this for me in Arabic, and I will translate it to English. But so the patient told me that you guys deprive me from talking, eating, and drinking, and you need to do something about it. And sort of it's one of those reasons that made me feel about what we do to patients in the ICU, and how we should feed patients properly because they're unable to get what they want. So for this, I will finish here. These are, I hope I tried to answer the questions related to what target we should use, how soon we should feed the patients, enteral versus parenteral, trophic versus full feeding. And I will stop here and see if you have any questions.
Thank you, Nabil. Very complicated topic, of course, but you dissected through the different studies very nicely, and you presented them in an elegant way, in a way that we understand nutrition in a better way in the ICU. My question to you, what if the patient stays with us in the ICU for a long time? After the initial 7 days, the patient would get better, and then what if this patient goes into septic shock again? Would you treat this patient similarly to the initial patient who presented to you with septic shock? In other words, would you go down on the calorie count for those patients if they go again into septic shock and become very critically ill during the course of the ICU?
Well, I'm glad you raised that. One thing I haven't talked about is what do we do after the first week? I think that in that stage, we are all very dependent on our dietitian. They're very knowledgeable, but we tend to gradually increase the calories, actually increase the protein, sometimes to 2 grams per kilogram, because that's the phase where we feel the patients now is in undergoing rehab, exercise, and they need higher calories and protein. Now, if any time during that prolonged course in the hospital, they develop another episode of septic shock, it seems that cascade of events with catabolism shutting down, changing the metabolic milieu in those patients would make us have to stop again and go back to this hypocaloric feeding. The gut doesn't, I didn't share with you some of the papers that talk about mesenteric ischemia associated with enteral feeding in patients that are getting vasopressors. So in those patients, pushing the feeding on a gut that does not like to get excessive feeding during that phase would be detrimental. And I think it would apply at any time throughout their course in the hospital if they require vasopressor. So I would decrease their calories and go down to lower levels. I think monitoring, the GI tract, abdominal distension, serum lactate, would help you to know whether that, can you slowly advance? So that's what I would do.
Thank you very much, Nabil. So if any of the audience have any question, you can raise your hand and I will give you the mic. Otherwise, you can put your question in either the Q&A section of the Zoom platform or in the chat section of the platform. At the same time, you can also place your comments on YouTube for those who are following us live on YouTube. So Nabil, if we want to simplify this, would it be appropriate to say that maybe on all patients, the first 48 hours target a trophic feeding and then escalate gradually by the end of the first week? And if you're able to tolerate enteral nutrition, would be more appropriate than parenteral. If the patient is in shock, requiring high-dose vasopressors, probably hold till the patient is more stabilized. If you see that the vasopressor requirements decreasing, we can start trophic feeding. Would that be an appropriate conclusion?
Yes, absolutely. I mean, that's a beautiful summary. As you mentioned, I think we always should start slow, build up in normal patients, but those who are on vasopressors, we need to be wary about them not tolerating that. And I think it's continuing with, and again, there's really no comparison between trophic and hypocaloric. We have hypocaloric versus full, trophic versus full, and they all seem to be the same. So you can choose whether you want to do trophic, which is like 25% of the calories in septic patients or hypotensive patients, and maybe hypocaloric and the others, and then aim for full after 7 days.
And that would answer the same, the first question that is placed by Sarah. She is asking about what about starting feeding in patients with high lactic acid level?
Yeah, I think if the patient have high lactate, I wouldn't start feeding at all. We want to see that lactate coming down close to normal and then initiating enteral feeding. But if the patient continues to have lactic acidosis that we think is related to hypoperfusion and association with shock state, then I would not start any feeding at all at that time until they're well resuscitated. So if even the early guideline 2016 said after the patient is adequately resuscitated, and in that sense, when the lactates start clearing.
Perfect. Ahmed Benjar is asking on those patients who cannot tolerate enteral feeding, when do you start TPN? Do you start right away or you wait till 7 days after the initial presentation to the ICU?
So I must say, I mentioned to you the difference between the European guidelines and the American guidelines. And for us practicing here in the US, and we work with our excellent clinical pharmacists, we usually don't start until 7 days, unless they have really severe malnutrition, pre-existing severe malnutrition. Then sometime we can, convince them to start it early, maybe on the 3rd day. But so it's a pick and choose, somewhere between 3 to 7 days. If I can't feed the patient enterally, then I'll start on TPN.
Very good. And Dr. Ahmed Hamdi Kuhail is asking that is there really any difference between different formulas? This was not covered fully. You mentioned that, Nabil, in one slide. You probably want to reiterate that, but he's asking whether it's going to be another lecture about different formulas in the ICU for nutrition, whether it's going to be helpful or not.
Well, I think those discussions probably going to be either sponsored by Abbott or Nestle. But as far as randomized trials, there's none of these companies that can show that one of their formulas are better than the other or better than the standard sort of mixture. There are some that have medium chain. It's called and the medium chain amino acids. Some of them contain fatty acids, variations for liver formula, variations for renal failure, and some of them have different sort of calorie fat for COPD patient. As I mentioned, there were some trials about adding special fatty acids for patients, thinking that this has antioxidant effects for ARDS. And none of any of these trials have shown any benefits. So any special formula that has been promoted has not been shown. The only thing I would say we have some formulas that are easier to tolerate from a GI standpoint. So for example, peptamen. Peptamen seems to be better tolerated. They're probably better for diarrhea patients because it's easier to. It's a sort of a digested material. So peptamen is one of those we use frequently in those situations. But as far as, so it's more related to the GI tolerance than the outcome.
Very good. Another question from Salah Hassan about nutrition in burn patients. And what about the use of prokinetic agents for patients who are unable to tolerate enteral feeding?
Right. So regarding burns, the only thing I'm aware of is really about the role of glutamine, which was previously promoted, and the large trial showed no benefit. As far as certainly they have much higher protein and calorie requirements. So this is a subset of patients that I personally am not familiar with, having worked with burn patients for many years, and it's not sort of specifically discussed or addressed in the guidelines. So I'm not going to give you a wrong answer in this regard. What was the other part of the question?
What about prokinetic agents,
Right.
erythromycin and metoclopramide?
So those we use very frequently. I think this is more of those patients who are not, if it's not related to hypotension or the use of vasopressors, but the patient have either high gastric residuals, vomiting, or constipation, then we use these variations between metoclopramide. Erythromycin seems to be more effective. And you'll be sort of watching the QT intervals. I believe overseas, I have used also domperidone, motilium as a drug to increase gastric motility. So these are, options you can use. There's a big shortage of IV erythromycin. So here we're using PO erythromycin. It's probably not as effective as I hear from our endocrinologist who deals with diabetic gastropathy. But I think that those would be helpful.
So let's get through the rest of the questions very quickly. We have quite a few questions still. Dr. Gitish is asking, so since the early Eden trial that showed no difference between the trophic and full feeding, have we learned much after that with all those newer trials? It looks like it's the same. What has changed?
I think it's the newer trial are reinforcing, because that was a subset of patients that were mechanical ventilation patients with moderate to severe ARDS. So, and people used to talk about, should we feed ARDS patients? So that argument shows that trophic feeding is enough for those patients in this acute phase. They had to deal a lot less with GI intolerance and gastric distension and so forth. So I think, the newer trials looked at, as we mentioned, vasopressors. So it's all reinforcing that we don't need to push feeding in the first week.
And you think that maybe the guidelines going to change after those new studies been released, that they less concentrate on early nutrition within 48 hours?
I certainly hope so. For some reason, I had a slide on the new guidelines, and somehow I maybe lost it in my adjustment for the slides. But so I think it's but the largest trial that I think is going to make a difference is the Nutria 3, which was published in 2023 after the asthma guidelines were updated. And they don't really update them as often as the sepsis guidelines. So maybe in the next few years, we'll see some statement in this regard.
Yes. A question here about a relationship between platelets count and lipids.
I'm not really sure. I mean, it's as far as
It's
causing
like
thrombocytopenia. I
causing
don't know the answer.
thrombocytopenia.
Yeah.
And I think this question, the next question, fluid restriction in lung disease, is not related to the topic of this discussion here. Sarah is asking again, is there a specific lactic acid level that you do not start feeding if you have it?
I mean, I would say anytime that, if the lactic acid is more than 2, I don't start until it normalizes. If I see patients starting, for example, 5, 7, and it's coming down with every 4 hours, then maybe I start a bit earlier. But I mean, I'd like to see it normalized.
I want to say that, within the first 24 hours, you resuscitate the patient and you see which direction the lactic acid is going. If you have a patient where lactic acid is going, and you do it every 3 to 4 hours to check the lactic acid. So if there's a rise in the lactic acid gradually, you would be very careful before you start nutrition for that patient. So the next question is for non-critical obese patients. What is the protein requirement? Would you use 1 to 2 or a different level?
Well, it's as I mentioned here in that slide, first, we're assuming these patients are, for example, just ventilated for COPD, obesity, hyperventilation. They're not septic. Then because if you want to just give them the amount of calories based on their ideal body weight, you'll be depriving them of a lot of protein. And in those patients, their actual body weight versus ideal body weight is like 3 times, sometimes 2 times. So if you do either a gram per kilogram per actual body weight, you'll be giving them enough protein, or you do 2 grams per ideal body weight. So it's depending on the different formulas, but we certainly give them higher level of protein to prevent protein loss as you try to allow them to lose weight.
Again, a couple of questions, Nabil. I don't know why they concentrate on those special formulas. It looks like there's lots of companies over there pushing for those formulas. They asking, what about glucerna for diabetic patients? And what about peptide-based formula in patients with abdominal surgery, intestinal surgeries?
All right, so I'm glad you mentioned it. So it's not going to affect the outcome, but glucerna is a formula that contains less sugar, more fat. So it's probably worth trying in diabetic patients, and those are difficult to control hyperglycemia. I found it's either this or you're going to adjust your insulin sliding scale. So whichever is cheaper. So it's not going to sort of be a factor that would allow you to get the patient off insulin. But in a difficult patients, if it's available, I don't know what the comparison price, but theoretically it's supposed to make you require less insulin. The next one would be what formula? I'm sorry, again. The peptide.
Peptide.
The peptide is what I mentioned. Yes, I think there is. Again, there's better GI tolerance. We use. I'm assuming this would be peptamen formula, but and I'm sure other companies have similar similar peptide-based formulas that are better for patients, either GI surgery, diarrhea, GI intolerance. So I see our dietitian often change the patients to peptamen in those situations.
Okay, one last question from YouTube comments. What about thiamine? Would you give this to all patients in the ICU?
Yes, it seems that thiamine deficiency is quite common. It will happen if your patient is on TPN for sure. We see it quite often in patients with alcohol abuse and malnourishment. So the recommendation, you forget about it, it's okay, because it's recommended to give it after the first week, unless you have somebody who's known to have history of excessive alcohol intake that you suspect thiamine deficiency to be pre-existing. but it will develop over time with enteral feeding and recommended to be given weekly.
Excellent. That actually answers all the questions. Thank you, Nabil, for elegant presentation. For everyone who's attending, please make sure that you give us your feedback after we end up this webinar. There will be 2 basic questions that we get feedback from you. Also, I want to remind you that September 13th is going to be another webinar by Dr. Hassan Hawa about how we conduct the ICU round more efficiently and comprehensively. Next week on the 15th, I believe, of August, we're going to have our ventilator round. They all at 1 p.m. Riyadh time, which is equivalent to, 9 p.m. Riyadh time, which is equivalent to 1 p.m. Chicago time or Central time. Thank you very much for your attendance, and hope to see you in the next webinar.